I'm Anne Vaughan. I'm a social worker at the IWK, as some of you were here at the previous session already know. It is my pleasure to co-chair this session with Katharine Filbert, and it is Psychosocial Issues When Treatment Challenges Feel Too Challenging, and sort of a global look at some of the psychosocial sides of a bleeding disorder. So I will hand the podium over to my colleague, Katharine.
Thank you, Anne. I'm Katharine Filbert. I'm a psychologist at the IWK Health Center. I work in the Pediatric Feeding Clinic and the Pediatric Hematology, Oncology, and Nephrology Service. And it's my pleasure to introduce our first speaker today, Dr. Michael Vallis. Dr. Vallis is a registered health psychologist practicing at the Capitol Health, Halifax, and cross-appointed to Dalhousie University as Associate Professor in Family Medicine and Psychiatry and Adjunct Professor in Psychology and Health and Human Performance. He obtained his Ph.D. and MA from the University of Western Ontario, London, and his Bachelor of Science from Dalhousie University. His main area of expertise is adult health psychology with an emphasis on diabetes, obesity, cardiovascular risk, and gastroenterology. He has developed the Behavior Change Institute, a training program for lifestyle counseling skills for physicians, nurses, dietitians, and other healthcare providers. He regularly supervises clinical and academic students at Dalhousie and is active in research on motivation, behavioral change, and adaptation to chronic disease. He is an associate editor of the Canadian Journal of Diabetes and Clinical Obesity, is the Canadian lead for the Diabetes Attitudes, Wishes, and Needs 2 study, DAWN2, is the Canadian co-lead and on the International Steering Committee of the IBD Connect project, and he was recently awarded a Queen's Diamond Jubilee Medal by the Government of Canada on the recommendation of the Canadian Diabetes Association. So I welcome Dr. Vallis.
Thank you very much. Oh, that came across loud. I won't have to speak that loud, and your voice was quieter than mine. So it's a pleasure for me to be here. I'd like to spend the next 30 minutes talking about health behavior change, something that I think is we've come to understand to be quite a difficult challenge. And it's really nice for me to present to an audience that's a mix of both providers and consumers, because I think we really need to establish relationships that promote change. And we live in a world that actually makes change very difficult, and so that's the essence of my talk. I have some disclosures. So I am involved in some advisory boards, and you may be familiar with the Novo Nordisk HERO study. Well, I lead a very similar study in diabetes from Canada called the DAWN study, and it has very similar purposes. I also regularly receive speaking fees from a number of companies to talk around behavioral issues. And I think probably my most important disclosure is for you to understand that this area is not my content expertise. So I'm here to talk about health professional relationships with individuals with chronic disease, trying to promote behavior change, so that you would appreciate that. The objectives of this very brief presentation, and I will try to keep it as brief as I can because I only have 30 minutes, is to talk about some of the psychological principles that extend medical management, which we're really, really comfortable with, into self-management, which is really what's important. I'd like to facilitate your understanding of how that shift happens. So if you're a healthcare provider, what is it that is kind of demanded of you to really support individuals? If you're a consumer, what should you expect from your relationships with healthcare providers? Gone are the days that if you're a doctor, that means you're in charge and you know everything that needs to be done. And so the shift in this relationship, we find, becomes actually really quite important. I'd like to review some very specific strategies that enhance chronic disease outcomes. And importantly, these address what we call motivation, so that drive to do all the hard work of change. How you can promote that when you're kind of iffy. How you change your behavior. Think of a New Year's resolution. Lots of motivation, not much success. And the failure around New Year's resolutions, we believe, has to do with the behavior modification approach. And then what we call emotion and relationship management skills. So the take-home messages here are that recommendations and education, what I think we'd like to call teach and tell. And in the medical system, we're really happy. We really like teaching and telling. And the challenge with teaching and telling is it only works when the individual is actually ready to be taught and be told. And when you start looking at many health behaviors, what we discover is that most people are not ready. There's iffies, there's buts, there's whatabouts, and that makes the process hard. And that we believe that there are patient-centered communication skills that actually help to increase readiness, and then behavior modification skills. So let's talk about medical management to self-management. Medical management is what happens inside the clinician's office, inside the clinic, inside the surgery suite, and self-management is what happens when the individuals who consume our services leave and go back into their world. And the context for this next section of my talk would be as follows. I like to make the following point as emphatically as I can to healthcare providers. And that is, never forget that you are an insignificant speck in your patient's life. That when your patient goes home and they have a conflict, they can keep their husband happy or their clinician happy. You're gone. They can hang out with their friends and do everything that their friends are doing, or they can sit alone, isolated at home, and follow your advice. Not going to happen. So I think as healthcare providers, we have to really recognize that if we're really talking about empowering people, so it's not teach and tell, it's collaborate and empower, then how do we do that? I'm going to show you some data very quickly. I just want you to look at this data and just don't worry too much about the specific numbers. But this is from the Dawn study. So this is what we've learned from the Diabetes Attitudes, Wishes, and Needs study. And the scale that's being used here is called the Patient Assessment of Chronic Illness Care. This is the best evidence-based, patient-centered measure that we have today, developed by Ed Wagner of the Chronic Care Model. And if you look across the axis there, those items are things like, I was asked how diabetes affects my life. I was asked about problems with medications and other forms of treatment. I was encouraged to ask questions. I was helped to set goals. I was helped to overcome barriers to goals. I was helped to reach out to other people. And you see the top line are indications of how often this happens. This is the percentage of people in that group who say this happens a lot. And then the lower group, not so much. And what's interesting is this is 4,785 healthcare providers in 17 countries on all continents of the globe saying that they're doing really well. And this is 8,596 people living with diabetes who disagree. So we think we're doing a good job, but when we actually start to tap into what's the lived experience of chronic disease, we hear a different story. And so the context then would look like this. A provider makes a recommendation. That's what we do. We're experts, so we're good at that. We like to tell people what to do. And people respond by saying, well, I'm not so sure, you see. And so now the question is, what happens here? This is, in essence, the kind of core of health behavior change. It's our idea to change. The people that we're asking to do the work, not so sure. And so if you think about it, what percentage of your patients follow recommendations without much difficulty? Or, if you're a consumer, how easy is it for you to follow the recommendations with no problems? And what you discover here is that it's less than you would like. And according to the World Health Organization, non-adherence to medication, a pretty core intervention in virtually all chronic diseases, non-adherence is between 30 and 70%. And so that is not an insignificant problem. And many of us believe that the pathway to improved adherence of a medical treatment is communication, not expertise. And so medical competencies are basically seen, the relationship that gets established between the healthcare provider and the consumer is characterized by what we call the expert clinician with the uninformed help seeker. That's the easiest relationship dynamic that we fall into. And it's actually very well founded. It's founded on principles of science. It's founded on principles of evidence, best practice guidelines, and deterministic knowledge that we create through these reductionistic methods that we have. And it leads very well to healthcare providers then telling people what they know and then teaching them what they need to do to follow through on what they know. Teach and tell. And so there's a good basis for the sort of current situation that we find. But in fact, this is what happens. This is Andy Capp for those who recommend Andy Capp, right? We make recommendations, and the response is, do you have anything else that might be a little bit more palatable? And so the expert model is really based on these competencies. Our job is to diagnose, our job is to treat, and our job is to evaluate outcomes. That's what we do. And therefore, the main factor affecting the outcome is how good we are. And that model works very well in some situations, but it does not work very well in other circumstances. And so, because this model implies that we're good at teaching and telling, and that works very well when the outcomes that you're looking for are actually controlled by the clinician. So in the emergency room, in the surgery suite, with medical procedures, when the outcome that you're trying to achieve actually happens inside the clinic office, then this deterministic model is your way to go, right? And it works very well when the individual consumer is actually ready to follow our advice. But when those conditions aren't met, it doesn't work so well. And why don't recommendations work so well? And as it turns out, recommendations don't work well because of a basic human principle of relationships. So I just want you to think about a behavior. Think about the behavior taking out the trash. And think of two situations. It's your idea to take out the trash, or it's someone else's idea for you to take out the trash. Now, is your reaction to taking out the trash identical in those two situations? Or are you more likely to follow through your own ideas versus someone else's idea? So this is actually a basic principle of human functioning. And when you look at the clinical exchange, typically it's our idea, the provider makes the recommendation, and yet it's the individual, the consumer, who has to do the work. And many times, the individual isn't really excited about these changes, right? And so this is the reason that recommendations only work when a patient is ready, when an individual is actually ready to engage in these behaviors. And we have to contextually know that change is very difficult. I won't belabor this because this is a kind of a complex slide, but this slide is probably one of the best evidence-based slides that we have as psychologists. And this is a model of personality and a model of how people stay connected. It's called the two-factor model. And what it says is that humans can be located in some space defined by two dimensions. Dominance. How dominant are you? Some people are very submissive, very quiet, very reserved. Other people are very bold, very direct, very dominant. And we all vary on dominance. And the second dimension is social ability. How socially connected are you? Some people are isolated and sort of cold. Other people are very gregarious and very warm. And this defines all of us. We can all be defined in this space. But what's critically important is how we stay connected. And this is what's called interpersonal, between people, complementarity. How do we match? And when one person is dominant, the only way to stay connected to that person is to be submissive. If you're dominant and the other person's dominant, you have a fight. If you're submissive and the other person is submissive, nothing happens. Where do you want to go for lunch? I don't know. Where do you want to go? I don't know. Where do you want to go? I don't know. Where do you want to go? I don't know. That'll go on forever. Someone's got to step up and say, let's go here. Now, I want you to read dominance for expertise. When an individual takes the role of the expert, they're by definition becoming dominant. So this is why this model is so important for healthcare providers to get their head around. Because the reason that, and in the healthcare system, what we like to say about consumers is that patients lie. Patients tell doctors what they want to hear. And by the way, the evidence supports that. And the reason is because they don't think that we want to know the truth. So what we need to understand is that dynamic can shift. It's also important to understand that change is very difficult. We now believe that health behavior is abnormal behavior. We believe that the human brain is no longer adapted to the environment in which it lives. And the human brain is characterized by three principles. The pleasure principle, which is why you like apple pies over apples. The path of least resistance, which is why you like escalators and elevators more than stairs. And the preference for short-term gain regardless of long-term consequences, which is why even though you hate yourself the day after you've pigged out, you continue to pig out. Because in the moment, you feel that it's... This is the way that human operates. We live in a world that makes healthy behaviors much more difficult. What we call the built environment, it is not very conducive to supporting health behaviors. It's much easier to actually engage in the unhealthy behaviors. And a lot of the reasons that kind of keep us together, a lot of the things that drive human behavior are actually not based on health outcomes. So we eat for comfort or for social factors, etc. And you can see the brain there. And all I want to show you is there's two operating systems in the brain. There are the frontal lobes. This is in the frontal cortex just behind your forehead. And this is what we call the executive functions of the brain. So this is the part of the brain that engages in logic, problem-solving, delay of gratification. Frontal lobes are fully developed in girls between the ages of 23 and 25. Frontal lobes are fully developed in boys between the ages of 27 and 29. And this frontal lobe functioning is what often leads to health behaviors. The other part of the brain is called the limbic system. This is our emotional centers of the brain. I want it all, I want it now. This is a much more primitive part of the brain, and this operates pretty much from the word go, right? How old is your child when he or she first says to you, "You're not the boss of me"? And that is about 18 months to 2 years. Right? So if we want to leave, diagnose, treat, measure outcomes, if that's not our role, what is our role? And what we believe is that our role really is to describe, how did you get to where you are? Predict, if you keep doing what you're doing, where is that going to lead? And focus on choices. Are you okay with that consequence of continuing your behavior? In other words, we're not the expert, we're just the collaborator. And it's not up to us to make the choices, it's up to you to make the choices. By the way, you have to live with your choices. And our job is really to collaborate with you to make sure that whatever choices you make, which you're completely free to make, you're actually okay with the consequences of those. The last thing we want is for you to get to a point where you say, I hate these consequences, but no one ever helped you to realize that you had choices at some point that might have avoided those consequences. So this is a sort of an alternative perspective that we believe. It's important that we look at how do we do this. And so I run the Behavior Change Institute, so this is what I spend most of my time doing, is training healthcare providers and educating consumers about these kinds of skills. How do you establish a change-based relationship? How do you actually get someone to a behavior if they're not ready? How do you help people make changes when they are? And how do we help those changes become part of a person's lifestyle? And I don't have time. I keep checking. I've got 13 minutes, so I'm not doing too badly here. And so a lot of the change-based relationship involves what we in the field call motivational communication. And these are general principles that should guide the relationship. So if you're a healthcare provider, just sort of reflect on this. You know, how familiar are you with these concepts? If you're a consumer, reflect on your experience of being with us. And ask yourself, how often have you heard these things? And so some of the principles that guide motivational communication is for clinicians to stop telling people what to do. Stop making statements. If I said to you, I want you to double your dose, you might say to me, I want you to shut up. Because I'm not interested in doubling my dose, because I'm already worried about the side effects that I have for the current dose I'm on, and I'm not so happy about this. So I don't want to have this conversation with you. And basically, that reaction is predictable to a statement. Where if I said to you, would you consider doubling your dose? That's a question. Then you might say, I'm not sure. Right? So now you've got communication. You can then take it to the next step. And by the way, when you do analysis of doctor-patient interactions, 80% of the words come from the doctors, and 80% of the things that the doctors say are statements. So this is a really important issue that we find. Expressing empathy, which is trying to understand how a person got to be where they are, in a non-judgmental way. Understanding that there's pushes and pulls in all directions, and that at the end of the day, what we're really trying to do is empower individuals. In other words, to help them feel the confidence to continue with these health behaviors in the face of barriers. And that's a concept that we call self-efficacy. It's a very well-established phenomenon. And so, in a nutshell, what I like to encourage providers to do is just to follow this very simple approach. Most of your interactions with consumers should start by asking them, listening to them, summarizing what you've heard so they know they've been heard, and then inviting them to talk about what it is that you want to talk about. In other words, communicate to negotiate. It's not that healthcare providers don't have some excellent things to say, it's just that they're not in charge and that they need to figure out a way of saying it in which it can be negotiated in a respectful, collaborative, and empowering fashion. We've gotten a lot of traction out of understanding readiness to change, and the way that we conceptualize readiness is what we call the traffic light approach to readiness. In other words, green light, go if you're truly ready. Yellow light, proceed with caution if you're kind of ready, but, and red light, stop if you're not ready. And so if you think about readiness, let's imagine that you're a smoker and the issue is smoking cessation. How would you know if an individual who smokes cigarettes is ready to stop smoking? And this assessment we train providers to do in about 30 to 90 seconds. So it fits into a 7 or 11 or 15-minute visit in a primary care office. And if a person were truly ready to stop smoking, then they would pass the following test. If you ask them, do you consider smoking to be a problem for you? And they say, absolutely. It's not okay for me to be a smoker. They're acknowledging that. And remember, the following principle applies to much behavior. If it's not broke, don't fix it. So if you don't think your behavior is a problem, why would you fix it? Right? You've got enough problems in your life. You don't need to add things that aren't there. So the first pass of the test is you have to acknowledge it. Those are the frontal lobes, the ability to own the problem. Second question would be, are you distressed? Are you in any way unhappy by being a smoker? And that's the limbic system. That's that emotional component to the behavior. You've got to have skin in the game. It's a problem that bothers me. Are you interested in becoming a non-smoker? There, now you've got a goal. Right? And are you ready to take action now? And so we ask those 4 questions, 1, 2, 3, 4, and we listen to the answer, and we code the answer as a yes or a not yes. You don't listen for a no, you listen for a not yes. Right? So you ask somebody, do you consider smoking a problem? Well, that's a not yes. Doesn't matter whatever they say. Everything that comes after that would put it as a not yes. Right? Because the person who's truly ready to stop smoking would say, absolutely, that's why I'm here. And then what we do is we assess that into red light, yellow light, and green light. And remember, one of those principles of motivational communication was non-judgmental. So this is just the way it is. It's fine to be a red light. One of the most important messages that we can send to citizens, to consumers, is if you're struggling to change, it's okay. Our job is not to judge you if you're struggling. As a matter of fact, our job is to support you if you're struggling. And rather than reinforce those people that are ready and leave alone those people who aren't. And then we guide people through that. So if you're green light, then you go right to behavior modification. And the way our talks today are set up is the next speaker, Dr. Chorney, is going to illustrate to you some really effective sort of, feet on the ground strategies around behavior change that can be very effective. But in essence, you go right into the behavior modification. If you're ambivalent, then you try to understand the readiness. Try to understand personal values, the meaning that people have behind why they do what you do. In other words, when you think about a health behavior, a question that I like to ask people is, what is important enough in your life to do this work for? Because you're not going to do it because I recommend it, but is there something in your life that's important enough to you to get up early in the morning to exercise? Or to stop eating high-fat, carb-loaded foods after 8 o'clock at night? Some health advice like that. If you're not ready, then you take the expectation of change off the table and understand behavior. And we psychologists are finding that this is tremendously valuable. When somebody is not ready to change, it's fascinating to then understand the reasons why they're not ready. And you will hear some of the most important stories. And those stories fit into what we call personal meaning and health beliefs. And there's a tremendous amount that healthcare providers can do to support individuals who aren't ready in reconsidering some of their beliefs. Decisional balance is an important concept in which there are reasons to change and reasons to stay the same. In the healthcare system, we like to talk about all the reasons to change, right? So if I was to say to you, give me your really quick response to the following question. Is smoking good or bad? Bad? You're wrong, and you're judgmental. And if that attitude leaks out to somebody who's smoking, you can never help them stop smoking. Smoking provides stress management. Smoking provides socialization. Smoking provides weight control. People smoke for reasons. And so you need to understand the reasons that people engage in their behavior in order to help them discover some alternatives and choices. Working with behavior modification involves really 4 steps. First step goals. What can be a very realistic, appropriate, doable step? So we talk about goals in the following way, because they're negotiated. They have to be doable, and that's the individual's judgment. I think I can do that. And they have to be worthwhile, and that's where the healthcare provider comes in. The healthcare provider and the consumer need to negotiate not only what's doable, but what's worth doing. And those are set up as first step and then next step goals, which we call behavior shaping. There are 2 strategies that involve the fact that behavior is often shaped by the environment. One of those is called stimulus control. How do you alter your environment? So those of you who like potato chips, I'll make you healthier in your potato chip consumption by allowing you to eat all the chips you want anytime you want. Just follow the following 2 stimulus control rules. Never bring chips into your house again as long as you live. If you want them, go out and get them. Remember, we're basically hunter-gatherers. So get them out of the house, go hunt them down. Rule number 2, you can never have more than 1 bag in your possession at any time, and it can never be greater than 75 grams. So if in your world, potato chips only ever show up out of the house in 75 gram bags or less, you will eat fewer potato chips. This is a hugely beneficial skill. And then reinforcement management. Set a goal, get a reward. Set a goal, get a reward. Just don't make food your reward. Supporting health behavior change often also involves the emotion management piece. And this is where we encourage healthcare providers to go down that pathway of understanding and supporting the emotional experience of the individual. They don't have to do all the work of change. Many healthcare providers are afraid to talk to patients about emotions. And what we recommend is that you don't have to do the work. You can identify, educate, recommend, and support. If behavior has a purpose, help people replace the function. If I'm an emotional eater, don't get me to change my eating behavior until you can give me another way of coping with my emotions. I need another way of serving that purpose. And then what I like to call the 4 S's. Self-esteem, the health behavior has to be owned by the person. Self-efficacy, your confidence in the ability to do it in the face of barriers. Support, you need to be surrounded by people who support that behavior. And then you need to find ways of managing stress. I'm just going to show you this slide. A lot of healthcare providers struggle with emotions, and they don't know whether, is the person depressed or what's going on. They're very confused. And the model that I've been getting some success with is this model. If you think that your patient is having trouble, don't jump to some diagnostic category. That's not fair to the individual. Ask your patient 2 questions. How unhappy are you? Distress. And how happy are you? Well-being. Quality of life is a balance. We're not just a series of problems. We also have skills and strengths. And then you unpack distress. To what extent is this distress related to your chronic disease? That belongs inside the clinic. To what extent is this distress associated with problems of living? And or to what extent is this associated with some mental health challenges that you might have? And this also allows us health providers to identify what are your strengths? What are the things that you do really well? How can we take advantage of your strengths to bring your strengths to solve the problem? My last slide, just wanting to show that there's a complexity here, and this is what we call the stepped collaborative care model. So my plea to healthcare providers is rather than to sort of think about, somebody's got distress, send them to a psychologist, but to work collaboratively so that we're all addressing not only the medical, but also the emotional, behavioral issues associated. So thank you very much. I appreciate your attention.
Thank you very much, Dr. Vallis. We don't unfortunately have times for questions or comments at this juncture. We're going to proceed to the next presentation, that of Dr. Chorney's, but perhaps at the end, if Dr. Vallis is available, you might be able to approach the stage and ask any questions or voice any comments at that point. So it's my pleasure now to introduce Dr. Daniel Chorney, who will be conducting a presentation entitled I Hate Needles, Overcoming Blood Injection Injury Phobia. Dr. Chorney completed his undergraduate studies at the University of British Columbia, Ph.D. from West Virginia University, and completed his clinical internship at Brown University in Providence, Rhode Island. Prior to starting a private practice, Dr. Chorney worked at the IWK as a staff psychologist with the Community Mental Health Program and as the team leader for the Anxiety Program. Please help me in welcoming Dr. Chorney.
Hello, everybody. So I'm really excited, to be here today to talk about anxiety in folks with hemophilia for a couple reasons, actually. I'm excited as I watched the talks this morning that we're talking about mental health issues. And we're talking about a lot of different mental health issues. I thought Dr. Tupper's talk about pain, as well as some of the other things we talked about in the personal stories that were shared. I'm sort of here today both as a provider, because I treat a lot of folks with anxiety, and as a consumer, because I actually have hemophilia A. Sometimes I think that I'm here today as an example of what not to do, because as Dr. Vallis was pointing out, I'm a model for non-adherence to treatment. And it took me about 29 years to actually start getting help. So that's probably about when my frontal lobe developed, as we just learned. So for a very long time, much like the stories this morning, I didn't want to talk about hemophilia. You couldn't have paid me enough to even say the words, I have hemophilia. But today, here I am. So I'm hoping to be a better model of what to do, but for a very long time, I never got any help for my hemophilia. No one pays me for these talks, but if anyone wants to, they certainly can. So, I'm going to start today by talking a little bit about anxiety in general. And so I often talk about anxiety broadly, and today I'm going to talk about one very specific thing. Needle phobia, because obviously with hemophilia, this is something that folks have to deal with very often, depending on the severity of their needs. So I'm fortunate in a way to be mild, and I don't often have to get treatment, although as I've learned from my excellent treatment team, the mild folks are sometimes complicated because we're not good about following up with things, and we're also exposed to scary things less, right? So growing up, I didn't see many needles, but now I see them more often. One of the first things to understand about anxiety, and it's very similar to what we learned this morning about pain, is that it's a very private internal experience. You can't often see it on the outside. It's made up of how you feel, how you think, and what you do. And it really doesn't always make sense. So, when I'm looking at this slide, you see these three pictures and you think, well, what would be the scariest thing on here? The massive bruise, the needle, or a medical alert. So I never even wore a medical alert until I was 18. My doctor essentially threatened me and said, because I was going traveling in Europe, he said, if I don't wear it, I could die, because if I'm unconscious, I can't tell someone I have hemophilia. So I refused. And talking about, readiness, what Dr. Vallis just sort of opened up with, I was not ready to hear anything from anyone for any reason. And so really it came down to that choice about, do you want to die or do you want to wear a bracelet? I actually refuse the bracelet. I wear a necklace so that no one can see it. And I really, for the first 18, 29, whatever years, I never told anyone, my best friend, folks I dated, it didn't really matter who you were, you didn't know. And as a really little kid, hearing Amy and Jay talk about their experience was really moving this morning. I don't think I met anyone with hemophilia growing up. And so I really felt alone. So hearing their stories about hiding it or being in denial and sort of not letting it run your life, that was really interesting to me because I felt very similar in not disclosing. My fear was actually that if my friends found out, that they would be afraid they would catch it. And I had a lot of friends, and I didn't want any of them, for passing around a water bottle, to think they're going to catch my hemophilia and make fun of me. So for a long time, I was more afraid of the factor first and medical alert. But then actually, interestingly enough, at 29 or so, I developed needle phobia. And I started passing out when I got needles here at the QE2, when I got my cogenate injections, if I got hurt. You could say that's funny, that it was spontaneous. They just came out of nowhere. It actually coincides perfectly with when I started getting treatment. For a long time, I just never got needles, I guess. And if I did, I just did one of these, which isn't very effective. So let's talk a little bit about needle fear itself. I always love, I've seen Dr. Vallis talk before, I love it when he says that healthy behavior is abnormal. I mean, needles, if you think about the fear of needles, and when I hear doctors sometimes say, oh, you shouldn't be afraid, it's ridiculous when they say that. Putting a metal object into your body is a very frightening thing. And it never really gets less scary because there's that part of your brain, that primitive part of your brain that says, don't do this, this is a bad idea. And so, talking about needle fear, you don't have to go far to find someone who's afraid of needles, especially with kids. And so you see a lot of folks today talk about, I refuse to get needles because of the pain or because of you're afraid of what's in the needle or how the procedure is going to go. But it really is important that as a provider, you understand that to be empathic about this and not simply brush it off and say, oh, just get over it. I'm going to talk today about some ways you can help in a useful sort of way. So blood injection injury phobia is a real intense fear of needles or the blood or what goes along with it. The biggest consequence of it, and like I was saying already, is that you can avoid medical care because of it. If you're afraid of getting a needle, this is obviously a big topic in the news today as well, people not getting vaccinations or people not getting care. But if you're just afraid of the pain or what's associated with it, you often won't go in for help. And that's obviously important for folks with hemophilia. One of the really interesting things about this phobia versus others, and phobias are pretty common, right? A lot of folks have a fear of flying or snakes or public speaking. Most of the time, when we're really scared of things, our blood pressure and our heart starts beating quickly and we get very aroused and we get sort of worked up. And it sort of stays that way for a very long time. And what happens over time is that sort of heightened state of tension slowly dissipates. What happens with BII that's unlike other phobias is that there's a really quick spike and a really quick drop. And for a subset of the population, they actually can faint. And like I said, that's actually what happened to me, and it became really embarrassing. I can tell a story at the QE2. They used to sort of give me a little bit of a hard time for being the anxiety team leader and also passing out at a butterfly needle. So, my goal today, it is a very quick presentation, is just to sort of give you some options for some of the folks here today who work with kids or adults with needle fears. And I'm going to talk about two different types of things you can do that are very specific. And so there's a supply tension and there's exposure, and they're two separate types of behavior modification strategies. So the applied tension really is specifically for those who are fainting at needles. And I'm going to give you an example in a second. Exposure is different, and exposure sort of is the foundation of treatment for any anxiety disorder. So whether you're talking about giving a talk in public, whether you're talking about getting a needle, whether you're talking about getting on an airplane, exposure is really what we know from research to be the most effective piece of treatment in getting over a fear. I sometimes tell families, we could talk about this forever, but until we actually start doing something, you're still going to be afraid of it. So it's important to sort of understand these concepts before you start doing them. I'm not going to go through each one of these, bore you guys to tears, but if you look up applied tension, what it involves essentially is counteracting that part of your body that's trying to make you faint. So when your blood pressure drops very quickly, doing an applied tension technique or helping a child or adult through that counters that. And it's basically a series of muscle sort of tensing exercises that you do before the injection and immediately after. I know for myself, I would get really worked up when I would go in, get the needle. Of course, everything's fine. It always is. And immediately after it went in, I started to relax very dramatically. And that's when I would sort of pass out. And that created a whole new sort of series of problems, right? Because then I became anxious about going and getting help at all. And like I said, for 29 years, I was a non-adherent patient. And so it became a struggle with the other people in my life. I was talking about collaboration. My wife would say, you really need, to go get some cogenate to get factor. And I'd say, no, it's a real ordeal. I pass out. It's uncomfortable. People make fun of me. So I really started to create a cycle of embarrassment as well. So fighting the fainting is a big deal. You also want to make sure that the patient understands that feeling coming on. A lot of people say it just comes on, and it does come on very quickly, but there are signs. So here are some of the most common things that kids or adults might feel, and you want to make sure that they're doing this applied tension during this so that their blood pressure doesn't drop. Exposure is different, and exposure is really, I think, what I want to spend a little bit more time on, because this can really help. This is basically taking a feared thing in your life, breaking it down to small, manageable steps, and helping a person fight their fear by facing their fear. That's sort of how we talk about it. And so what I've done here is just sort of drawn up a really quick example of what this might look like. And so if someone is, deathly afraid of needles, sometimes we start by just saying the word needle or writing the word. And then we can sort of build up. You can see how these get more and more complicated as you kind of go through this. It's important as you do this, because I can't remember who it was this morning, but someone talked about distracting themselves. And it's important that folks don't distract themselves during this process. While that is effective for very young children, as an adult, I can tell you that turning your head away and pretending like it's not happening is one of the worst strategies you can ever do, because your brain is smarter than you. It will tell you what's actually happening, even if you're trying to pretend like it's not. And we know a lot now about thought suppression. The more you try to not think about something, the more you actually think it, right? Go on a diet, don't think about donuts, right? All you do is think about donuts. So if I try not thinking about a needle while I'm getting an injection, I'm actually getting more worked up about it. So don't advocate for distraction, folks. Getting over it does take a little bit more work, and like Dr. Vallis said, sometimes we're not primed for that. We like to take the path of least resistance, which is just sort of this, but it's not really an effective long-term strategy. When working with kids, it's important, or adults, to make sure that they understand and you're sort of gauging with them where they fall on the anxiety curve. So you can use a similar stoplight type of analogy, green, yellow, red. But basically, if someone's sort of low on that anxiety curve, they're fine. If they're in the middle, it's still time to talk. But if they're at the very top of the curve, if they're really, really anxious, it's important that they focus on reducing the physical symptoms of anxiety. So breathing, helping helping bring down their tension and overall muscle sort of tension as well, and helping folks understand that anxiety actually follows this curve pattern very reliably. We get anxious, it comes down. We get anxious, it comes down. It never really changes from that. A lot of kids and adults will say that they're, afraid about something specific about the needle itself, whether it's the contents or how much it'll hurt. So what I've tried to do here is give some helpful sort of questions that you might want to help ask that person in that sort of moment, or not sort of right in the moment, but before the injection itself. And again, this is so important because we talk about home care and folks self-infusing at home, especially even this morning talking about Bangladesh and all that. Like, if so many folks are doing this and they're refusing home care because of needle fear, it's important that they think realistically about it. So one of the most common things you'll hear is, it hurts. But when you actually push a little further, people will reliably say, yeah, it only hurts for 1 or 2 seconds, and then that sort of pain dissipates. So helping them at least say that out loud, and you can even practice this. Sometimes with kids, they'll say, 1 or 2 seconds, and it hurts like 8 out of 10. Can you pinch your hand for that long and then let go? And let's practice feeling that pain over and over and over again so that you understand it is going to hurt, but not for very long. That sort of habituation that I'm talking about today, that can be really helpful. I wanted to throw this in here, but I want to make sure I leave time for questions as well. This is a cool study that I actually found just as I was preparing to give this talk. And so basically, and this was important because Dr. Tupper touched on this this morning when she said that people's perception of pain changes depending on the context, okay? Didn't even know she was going to say that. Super cool that I found this study, because all these folks did was, if you look at the picture, so let's take the big needles, exactly the same needle, and they just put little friendly stickers on them. Okay, this is like a dollar store intervention. But when you look at the scores, you probably can't read that. It says that changing that, so putting those friendly stickers, yielded a mean 79% decrease in aversion scores. In mental health, that's massive to get that sort of an effect, especially for a dollar store intervention. So all we did was change the context. It went from a super scary needle to it's a thing with stickers on it. It's very simple, but changing context changes perceptions, whether it's pain, whether it's anxiety, you name it. So looking at things like this is really important in terms of helping people take that step from sort of theory to practice, actually putting a needle inside of you. I've given this talk once before, and I love to sort of take a little chance to give a huge thank you to the treatment team here. It was really cool actually this morning to see the patient satisfaction data. And so, talking today about being both a consumer and a provider, it's really interesting to be on both sides of that table. And the treatment team here in Halifax, so especially, Dr. Robinson, who stepped out, I think, and Sue Van Oosten, really helped me come a long way. So I went from, for about reliably a year, passing out at the QE2 whenever I had to infuse, to doing home infusions now, and I do it pretty reliably. And it was interesting also, and I always tell her when I use my Cogenate. It was really interesting, too, to hear about Jay's story when he talked about, getting poked 20 times. I can tell you now that I'm not anxious about needles. I certainly am very angry when I miss, and I've certainly missed a good number of times. But I'll take angry over scared any day. I just have to give myself a little bit of time, focus, and get better. It's a huge sense of accomplishment to be able to get over this type of fear. And I think when you see kids or adults get over it as a provider, you also should feel a big sense of accomplishment as well. So just a huge thank you to those guys who are here today. And I think we have time if folks have questions. I'm happy to answer questions here today about the injection fears, social anxiety, and hemophilia, the stuff we talked about with sort of being embarrassed or shy to even discuss it, or any sort of other things about distraction and exposure. Yeah?
So we treat a lot of children, very young children, with severe hemophilia, and more the world is moving towards primary prophylaxis, where you start infusions often fairly frequently at ages 1, 2, 3. A lot of the techniques that you talked about, they suggest that you need a certain level of, cognitive maturity,
Sure.
which may come when you're 29, but it usually doesn't come when you're 1 or 2.
No.
So what do you suggest for the people in the audience that are caring for such young children and are starting them on 2 or 3 infusions every week?
Yeah. No, that's a good point, and absolutely right. So when I talked about distraction being a relatively poor strategy, I was talking more about older kids sort of getting up in age and into sort of early adolescence, teens, and adults. For very young kids, the emphasis is actually on distraction and pain reduction. So using sort of the EMLA creams and things like that, and helping make the whole experience less scary and aversive. I think, again, going back to the story shared this morning by Jay about how scary that is to have a really bad experience. It sort of sets the bar for future experiences. So for 1 or 2, it's tricky because they're not going to sort of cognitively remember those specific experiences, but it could sort of set the stage for a very long childhood of difficulty with that. So again, once they get old enough into maybe, let's say, that 4, 5, 6 range, the exposure that we talked about here is an effective strategy because you don't actually have to do a whole lot of talking, it's a lot of doing. So that would be the drawing, like even coloring pictures of needles. In my office, I'll have folks hold syringes and things like that so that they're not afraid of the thing itself. Because, for me and for a lot of folks, just the cues trigger the anxiety. So hearing the sound, I was going to borrow this, hearing like the sound of the package opening, for me, what gets me is the alcohol, the swab, right? Oh man, when I smell I'm immediately, like I have to take a few seconds. You know what I mean? To sort of let myself calm down and then make sure, and I learned a little trick from Sue Anderson, don't go poke when it's alcohol, it hurts. So, using those kind of exposure techniques could be good. And you're right, not talking, you don't talk very much to 2 and 3s, they wouldn't get this. Yeah, good question, though. Dr. Christine Chambers, she's a local psychologist. She does a lot of work in needle pain. If you want to Google her, she's all over Twitter. She does a lot of work in that area. Yep.
I'm Erica. I'm from Vancouver. I work at BC Children's Hospital.
Hi.
Young children, this is actually to kind of follow up on Dr. Carcao's question, are often oriented by their parents and the other providers in the setting to what they should be experiencing when they're getting needle pokes. And we come in with all this EMLA and distraction and all these kind of orientation tools saying, this is going to hurt. This is what we're going to do to help you.
Yeah.
And so the kids are often oriented to what kind of experience it is anticipated. Yeah. Is there any, in your experience, strategies that are helping parents cope with guiding their children around this?
Yeah, you bet. Yeah, I spent many a day at BC Children's as a kid with hemophilia. My mom, who was wicked anxious, and she did not help at all. She love her to death, but she was very anxious, and she actually passed out when she saw me. I have a big scar here, and so, when I would bleed out as a kid, I got 14 stitches. She passed out at the pediatrician's office. So helping them, yeah, and I wonder why I'm anxious. Helping those parents understand that sometimes what they're doing to try to be helpful is actually hurtful. Hearing Dr. Vallis again talk about readiness for change, I can tell you I have personally, or professionally I guess, been yelled at by mothers who are not ready to hear that message when I try to broach it in my office, that I think that some of the behaviors you're doing are making your child's anxiety worse. So walking into an office and, okay, don't panic, don't look, you're going to be okay. That sort of message, just think about yourself. When someone walks up to me and says, I'm going to tell you something, don't get mad, right? We don't do well. We don't control our emotions very well. Emotions kind of follow that pattern. And so when you prime someone to be anxious, that part of your brain, the amygdala, it starts spitting out a message, something's going to happen, something's wrong. And that message that parents can give, again, you can be empathic and you can say, look, I know that this is extremely difficult for you as a parent to see your child experience this pain. This pain is temporary. This pain is for their benefit. And if this procedure goes well, they can come out more resilient and strengthened from it. And helping that parent understand that they might have to manage their own anxiety as well, because they're making the experience worse for their children. Again, some parents are very open to that message and very thankful to hear it. Other parents can get very upset and they can be very accusatory and say, how dare you tell me, how to parent my child. The letter this morning that was read, there were a few things in that letter even I was listening to talking about an avoidance kind of coping model, sort of like being very careful and using strategies that weren't focused on building strength but focused on avoiding pain. That can lead to long-term difficulties. And again, piggybacking on the previous talk, short-term strategies are very rarely good in the long term. But we're hardwired that way, right? 29 years, I was like, no thanks to needles. I only changed because I went from red light to this is embarrassing, this is hurting me, people are making fun of me, and I had a team that was very supportive and willing to help me get over it. But I wasn't ready for that until that moment. So, yeah, the environment plays a huge role. Yeah, that's a good question. I think we have time for another question. Yeah. No? Oh, you're telling me to go away. Oh, yeah. No. Yeah, please.
I'm Joanne Nilsson. I'm a physiotherapist with Saskatchewan. And I just wanted to make a comment in follow-up to Erica's comment, too. In Saskatchewan, we did a little bit of a questionnaire with parents about needle fear, needle pain, and we found that it was often, it took a lot of time because you need to educate the parents, and sort of tried to go more of a preventative measure to try and avoid that needle fear from happening. And so it was a very interesting thing, but we found that it was really a multi-team approach, because often their home experiences were really good because the nurses and everything were able to teach a really good scenario, but it was often that one emergency visit that kind of, it was that one experience that caused it. But thanks very much. Good talk.
No, absolutely. I can follow up on that comment quick, too. I mean, all it took for me was to faint one time before it became a whole process that was very hard to reverse. And so with a lot of anxious sort of situations, that really scary first experience kind of can set the bar. But once you slip into that model of avoiding whatever it is that makes you afraid, helping kids understand that anxiety grows with avoidance. It never, ever, ever gets smaller. And the tricky thing, especially developmentally for a child or young adult, is helping people understand that avoidance will eventually catch up with you. You can only avoid something you're afraid of for so long, whether it's flying, whether it's getting an injection, you name it. At some point, you will have to face that fear. So making sure that prevention is part of your strategy. And so, again, that's why I'm so happy to be talking about mental health here today, because there's so many mental health topics, I think, related to hemophilia that are worth addressing. Oh, there's a question way over there. We have 2 minutes.
Hi. I was just wondering what your thoughts are on young children observing older children infuse in terms of maybe preparing them psychologically. Does that have any tangible benefits?
Yeah, younger children watching older children, you mean as positive models? Yeah, so using a positive model to learn a health behavior or a coping strategy is excellent, as long as they're modeling positive behaviors, right? So one of the things with needles, and again, I mentioned Dr. Chambers, she does a lot of stuff with early infancy and needles. One of her big things is really getting at the media and press for whenever we talk about needles, you put up a picture of my picture, right? That guy. So I'm doing it here today, but I wouldn't actually do this if I was giving this talk, you know what I mean? Or not to kids, I wouldn't show this. I do it here because it's kind of funny, but I mean, when we show this message over and over, we're modeling, just like what you're talking about, that needles hurt. Versus look at the guy on the right, he looks perfectly calm. So if he were my model, I wouldn't be as afraid as if you had first exposed me to the picture on the left. That's a very sort of basic psychological principle. And actually, these kind of pictures helped me. It was going to camps and working a little more with the hemophilia folks locally, where I got to see so many kids. You know, there's like a, 7-year-old, and I was 29, and I couldn't do it, right? I have a Ph.D. in clinical psychology, and I'm a anxiety leader in the, it was ridiculous. So that really, it honestly, when you talked about going from red light to yellow green, seeing a 6-year-old do something really pushed me along. So that's a good message. All right. Thank you so much, guys.
Thank you, Dr. Chorney. I'll welcome Anne Vaughan back to the stage to introduce the panel discussion.
I'm not going to waste any time talking. I'm just going to go right to it. We have 4 wonderful panelists who have agreed to come and speak with us. I'm going to ask each of them to introduce themselves the way they wish, but we do have a parent, 2 people who are living with hemophilia, and a nurse from one of our clinics. So we'll start with Guy Fortin. Stay right where you are and be comfortable.
Hi, my name's Guy, and my 17-year-old son has hemophilia.
My name's Glenn Von Wheeler. I'm a severe hemophiliac, and I'm from St. John, New Brunswick.
My name is Isaac. I live in Fredericton, New Brunswick, and I have severe hemophilia A.
Sue-Ann Hawes, pediatric nurse from Halifax, and I think Guy's now going to give us a story on his perspective.
Honestly, I had 2 motives coming here today. The first one was I thought that my story was important, and the second one was to try and get an afternoon off from my physical education teaching job. Everything was fine till, I have to say, Dr. Vallis got up and started using words like teaching and behaviour and outcomes and recommendations, and then I sort of got caught in the days thinking I was at a teacher's conference. But the irony behind that is that the key behind all this is education. When we first come into this, it's new. We didn't know anything about it because it was new to our family. It wasn't in our family, so everything was just completely new to us. So education was the key. And I have to put everything into context a little bit. We have a family of 5 kids, very active, very physically active. So putting the brakes on and the red light, there was no red light in our family. The light was always green. So that made things even more difficult because starting with the eldest in our family, my 22-year-old daughter, they were really, really involved with sports. And of course, the siblings wanted to do the same thing. So my perspective on this whole thing is that in 17 years, we went really from not really knowing, not thinking that he would have a normal life, but not knowing if he would. And with the help of a great team here in Halifax, and again, being educated 17 years later, I can really tell you that this kid had a normal life. So I'm just going to revert to my notes here. I heard the word disease a lot, and I mean, I'm not a physician, but right off the get-go for us, this was not a disease. This was a condition. Disease often is associated with illnesses that can even be terminal. So we always dealt with this as a condition, and having a condition meant that you had to learn to live with it. You had to find ways to move forward on a day-to-day basis. And that came easy for us like I said earlier, because of the support we had here at the hospital, he had a great team around him, but also because he had parents that did not put the brakes. Our reflex, and I'm not speaking for physicians, but maybe as a physician, our mandate is to want what's best for our patient, and we want that as parents for our kids. And sometimes I find as a parent, that clouds my judgment. I'm putting the brakes on when I shouldn't, when really what I should do is just watch and listen to my child, and he's going to tell me what to do. And if you give the opportunity to your children to be able to do things and say things they want to do and say, everything else just sort of comes naturally. This hemophilia thing for Dominic has never been an obstacle. It's never been a problem. And really, he sees it as a blessing. Because along the way, he's realizing that he's not so bad. Like, there's people that are worse off than he is, way worse off than he is. So not being educated at first and finding out he had this, yes, it's a huge thing. But along the way, him realizing that there's people that are far worse off than he is makes it a great learning tool for life. And that's how we approach this whole thing for the last 17 years. And I sort of have to go back to a trip that Dominic made 6 years ago. He just, stroke of luck, he ends up in the skybox at a hockey game. And there's I think there was 5 children there from the Maritimes. One of them who had a condition, I'm not sure what it was, but his movements were very limited. He was basically in a wheelchair, an electrical wheelchair. And Dominic was sitting with me at the bottom of the skybox watching the game, and Mark, I think his name was at the top, and Dominic said, "Dad, I'll go up and sit with Mark." I surprised myself asking Dom why. That was just a dumb question. But the answer really surprised me. He said, because he can't come down. So really, at the end of the day, this is not that bad. And if you learn to manage it, then you can have a normal life. And he does. He's very, very physically active. I mean, he competes at a national level in a very aggressive contact sport. And I don't know if anyone at the table wants to hear that. We did get cross-eyed a few times, but again, it's manageable, and he's got no target's joint. He's got no serious issues. He's got nothing he has to worry about for the rest of his life, even though he's been competing at that elite level in 2 sports. So this is very manageable. So from a physician standpoint, and I think from a parent and a patient standpoint, we all have to realize that at the end of the day, everything is what we make of it. And this wasn't difficult. This was natural. It was just a matter of accepting it and dealing with it.
Thank you.
My, times have changed. I was born in 1961, and the only treatment for hemophilia was reactive. So if you had a bleed, you had to haul yourself to the hospital, get your factor, and you'd be in the hospital for a week, 2 weeks, a month. By the time I was 12, I'd spent probably over a year in the hospital from bleeds to my knees. I'd have a bleed in one knee, I'd be in the hospital for a month. They'd let me out. I'd favor the other knee. What happens next? I have a bleed in that knee. By the age of 13, my parents were beside themselves. I was missing a lot of school. They didn't know what to do. They heard of a home infusion program at Sick Kids Hospital in Toronto, and they thought maybe that's a solution. So what did my parents do? Pop me on a plane, fly me to Sick Kids, and get the hematologist to teach me how to self-infuse. Came back to New Brunswick, handed the hematologist the letter saying that I'm qualified to infuse, and that was the very beginning of home infusion in New Brunswick. So a year in the hospital from age 1 to 12 From age 13 to age 54, I have not been in the hospital once from opportunistic bleed. So that's 41 years of prophylaxis. And I have been in the hospital, I've had knee replacements, but even the technology for that is much better now. Now, instead of giving you factor before and after surgery, they have continuous infusion. So I have surgery, I'm in and out of the hospital no longer than anybody else. So that's basically my story. You know, I think it's a success story.
Well, I'm going to start off by, I got my portacath at age 1. I hated it, just saying that. Age 7, I got it taken out, started self-infusing. I managed to control my own bleeds. Now I don't need my parents. I don't even think they know how to stick me with a needle now. I started when I was younger with infusing when I just got bleeds, but I got bleeds so many times in my target joint in my ankle. So we started doing it once a week. Then that kept getting lots of bleeds. Then twice, stopped getting frequently bleeds. And then we went to 3 times a week. Then it sort of stopped there. So I haven't had very many severe bleeds. Main reason I've gone to hospitals is soccer balls to the head and running into walls. I have been doing home infusions for over 7 years now. I've started, a couple years ago I started getting off track with my needles. One time I didn't even take a needle for a month. I got a bad bleed. When I went to go for my regular checkup in St. John, my dad told my nurse, Louise, and I got in trouble from like 8 nurses and doctors. Not fun. So then I started getting back on track with them telling me in the mornings for needles. My phone reminds me every morning when I get up. In the summer, I find it's harder because I sleep in a lot more because there's no school. Yay. And so I find it harder to remember because you're in the afternoon. So with my phone now I can remember with it reminding me. I find prophylaxis very well because my family didn't really have it when they were younger, but since now it's gotten better. I don't have to get blood transfusions. I can just take my factor at home. So, yeah.
So I've been a hemophilia nurse for over 20 years. So I've seen how the changes, not quite the changes back that the elderly gentleman talked about, but changes over the last 20 years of how this nice young man beside me. But I think that we all know that prophylaxis has made a big impact in the lives of many hemophilia. So I think for myself, I can empathize with some of the families, what they go through. As a chronic condition, as Guy said, it's not a disease, it is a condition. It is something that you have to learn to live with for your life, and you have to learn how to manage it. And having a child, myself, with a chronic condition, it is hard. I mean, you do get through it, but it is hard, and there's times in your life where you think, this sucks. And I mean, even the kids themselves, they go through periods of time where they don't want to deal with it. So I think, as a healthcare team, we need to help them manage it. It's hard to do it alone, so we're there to help. And I think, through Dan and Michael's talks, really, we have to engage the families. We have to allow them time to learn, plus have time to learn the choices and help us with the treatment plans. I don't think we can no longer dictate to the families and patients what they need to do. if you educate, they will know. And as you can see from what they've talked about today, that they end up tailoring things to the way they need it. And I think with our help, that's the key, is to tailor the treatment to what works for them. So just some of the challenges that I've experienced with families along the way, and because it is a chronic condition, if you're a family like Guy's family that have not had any past history and it comes along without any warning, that's a huge shock to the families, and you have to learn to accept it. Plus there's the big education piece as well. You go through the infant and toddler stage where, it is difficult doing treatments. Often the kids have to have portacasts, so that's a big learning curve. You can see from Dan's pictures that kids are not usually going to sit there with their, ready for an infusion, whether it's a port or a peripheral. So all those things have to be taken into consideration. And I think for, again, the healthcare team, we need to be there to help them. So, early consults to psychology, child life, all those things help the families learn how to deal with it. I think, too, that, it does take a while to get comfortable with hemophilia as a patient or a family. There's a big curve of learning, when is a bleed, like when do I treat, how do I rehabilitate from it? So again, physios help, nursing help, physician help, all those things, we're there to help. Again, I think, we can't dictate, and that's the choice that we talked about, is they have to be ready to do it. The other things that, I think it's difficult for the younger patients is to realize the long-term impact of hemophilia, and I think because they can't really see the impact, they think, why do I have to treat? And, I've had experience with some of my young guys, and Isaac here kind of talked about the fact that he didn't do infusions for a while. Well, some of my patients would take a holiday from treatment. Why bother? And they would get the big bleeds, and then they'd realize that, yes, they do need their treatment. So eventually they come around to realize that it is part of life, and they do have to treat. And I guess for parents, too, making decisions about your children, it's difficult. You want to do what's best for them, but also you want to know, like, is there risk for inhibitor there? Like, what am I doing to my child? So often, I think those decisions are hard for families to make. So as I said earlier, I think that, us working with families, hearing them, listening to them, coming up with a treatment plan that works for them, that's our success. And I think through what Guy talked about for his family, that really engaging his son early on, having him part of the process, because it is him, and, learning to self-infuse early, like Isaac did, like all those things are key pieces that we as healthcare providers really need to engage the patients and have them on board, because it's not going to work if we just sit back and, like Dan says or Michael says, dictate things to them that they're not ready for the change. So I think the other piece too is we have looked at ways. I think the whole healthy lifestyle piece is really something that's very important, and I know we've heard that from other talks today, and we're going to hear more about it this afternoon. But with our ability, with the prophylaxis, I think now that we're able to help our patients be healthy and have healthy lifestyle, do some of those activities that, years ago were just not an option for many of them. So I think that, individualizing plans is something that we have kind of looked at for different patients too, to be able to provide them with a lifestyle that's good for them and healthy. So I think that's pretty much all I wanted to say. I think really it's just key as healthcare providers to have open communication and provide as much education and make sure that our patients and families really understand what it is that we would like them to do, but also, what's best for the person that has hemophilia. So thank you.
We have such a brilliant session with our speakers and our panelists that we have saved some time for questions, and I invite anyone with questions to come forward.
The thing is, how do you get medical professionals that do not know you, especially to listen to you after you pass the age of 60, which our The young fellow up there has got a few years to go yet before he gets there. I would like to have the answer to that, please.
Yeah, that's a really great question, actually. It raises actually a really important issue, and the issue that you're describing is one of bias, of clinician bias. What are the biases that we bring into our work? And I think one of the disadvantages of the expert model is that we just assume that we don't have any biases because we know. And so I don't actually have an answer to your question. I think what I have is sort of a hopeful response, that as we let go of that expertise, then we actually become better able to listen. For me, I think the advice that I would give anyone who doesn't feel that they're being heard is to try to ask their clinicians a question, which is, are you okay with the fact that I don't think you're listening to me? That is a patient asking a doctor, are you okay with the fact that I don't think you're listening to me? And if you said that to them calmly, because one of the things that we need to appreciate is that the providers really do want to help. So they're not okay generally with this lack of communication challenge. And so if you could actually almost like hold up a mirror, and if they realize the effect of their words on you, I think that would do a tremendous amount to just kind of stopping them in their tracks and then sort of putting down their paper and perhaps opening up their eyes. But it reflects that issue that sort of expert model tends to close your eyes and your ears. And I think providers are very open. We get huge positive responses for the messages that we're trying to send from providers. We, often find that when we give our talks in the BCI, we get invited to do 2 more talks every time we give 1 talk. And so I think that providers are actually very interested in becoming more comfortable with that.
Just a quick comment. We were talking about role models for self-infusion. I just wanted to remind everybody of the existence of the self-infusion video. Self-infusion, confidence, autonomy, freedom. And here we do have kids talking to other kids on what it gave them to self-infuse. If they are afraid of infusing, they will get some good answers and the good reasons why to start when they're ready. And there are no better people than the same kind of people to tell them when and how and why they should do it. So we have plenty of those at the office. Don't hesitate to order some. You can order some here at the table or send us an email. We'll send you a bunch of those.
Thank you. Kathy?
Kathy Mulder, I'm a physiotherapist from Canada. I would like to ask Guy, I might have missed this, but what severity of condition does your son have, and what are his sports?
Dominic has severe hemophilia. He played AAA Bantam hockey and then gave it up because he made the provincial volleyball team. And this year he's on the men's U18 provincial team, volleyball.
Very good.
Christine.
Christine Kilback from Manitoba. I work for the Hemophilia Society there. In having gentlemen come into our office with hemophilia who are over 40, because we're very interested in the aging population, in discussing their target joints and their chronic pain, and they always seem to be a little bit angry and feeling a little hopeless. Whenever the topic of prophylaxis comes up, they go, "Oh, I don't want to do any more needles than I have to." And I find like it's almost a needle phobia itself, because they are obviously having to treat for this chronic joint, but they're not willing to even entertain the idea of going on prophylaxis. So is this just a different form of needle phobia?
So I'll start, and maybe Daniel can finish the answer to that. I see this quite often in diabetes as well, with you talking about switching from type 2 diabetes oral medications to insulin, and that the report of that reluctance to go on any type of an injectable. And I think it's really interesting that we sort of examine that, because there's really 2 components to your comment, that there might actually be a phobic component to that, but often it's an attitude issue, and that's where we often recommend that a provider would just sort of take that. So we're talking about the behavior of prophylaxis, and so do you consider not using prophylactic methods as a problem? Patient would say, absolutely not, I don't want to do this. Are you distressed by not doing it? Are you kidding me? I'd be distressed to go on it. Are you interested in going on it? I don't think you're listening to me. I don't want to do this, right? So what you'll be able to expose very, very quickly is this person is redder than red can be in terms of that stop right there. And then what we can do is we can say, we get it. So you're not interested in going on prophylactic treatment. So that's your choice. I respect that. You're not going to go on prophylactic treatment. Given the fact that you're not going to go on prophylactic treatment, I'd like to understand why. Can we talk about the reasons why? And now what you've done is you've given yourself an opportunity to understand the health beliefs, the personal meaning, the attitudes, and we find that those individuals are actually, I love to see those individuals clinically, because what I've found is that when you actually take the expectation of change off the table, they have some amazing stories to listen to, and it's in the listening to the stories and understanding those stories that then the communication often happens, and then they may never go on it, but it's surprising to see how many people actually start to have a different perspective and to be open to learning. And then there'd be the phobic component of that. I don't know, Dan, if you want to speak to that.
I'll just say one thing quickly. I think you mentioned the anger, frustration, and that's something that resonates a little with me. I think there are days certainly where I wake up and it's just very frustrating, and there's sometimes nothing more frustrating, like we've talked about today, than a treatment provider just throwing things at you, especially as a consumer, if you don't feel like they're really understanding or sympathetic. I feel like sometimes, especially as someone who has a more mild form, it's kind of like, yeah, but you should, just take the needle, just deal with, like, it's sort of it's hard to explain, but I sort of sometimes want people to be like, yeah, it might be mild for you, but that really sucks. And I can see that you're really frustrated. And you're not like your buddies who can go play football or jump off high things and do that kind of stuff. So I think there is that frustration piece. And sometimes I know, especially growing up, it was feeling like misunderstood, that no one really got it. And people just kind of throw recommendations at you without being empathic. That's why I like some of the suggestions, like, okay, so this isn't working. What would you like to do?
Two more questions.
First, I want to disclose that I used to pass out in med school every 2 weeks when during lectures they would show blood, but ended up being a hematologist anyway, so you can overcome fear of blood too, I think. My question was for Dr. Vallis. So how often do you have to see someone to start acting on changing behavior? In other words, is there a regularity? If you see someone once a year or twice a year, do you have any hope of affecting change, or do you have to schedule every 2-week visits? Or is there, beyond the principles, is there also an intensity of the ongoing relationship that really works, or it's not necessarily that frequent that makes it work?
So I think I like the question, and I think how I would encourage us to think about the answer would be that when we think about, okay, what would be the protocol? That's the word we would use. What would be the protocol? What would you expect? And we need to understand it not so much in terms of here is the pathway and we have to implement this protocol, but process. That is, what happens after step 1? It's the response to step 1 that would predict what's going to happen with step 2. So some people will respond very quickly. Some people can only tolerate you for so long. Like when I see people, right, it's like, how long can you talk to me before you start feeling defensive? And so if it's 2 minutes, I'll spend 2 minutes with them. If it's 30 minutes, then perhaps I can do that. So you start looking and sort of see how people would go forward. But I think the main point I would say is what we're really talking about here is teachable moment. That experience that you create in which the person kind of gets it. And what's interesting about teachable moments is that they come in all shapes and sizes. And so what we encourage people to do is say, well, as a healthcare provider, what is what can you provide in the system? How often do you frequently see patients? So what can you do with the time that you have and the frequency with which you have? And then not think about it that somehow it's your job to do all this work, but what can you do as a collaborator in a comprehensive care team that includes not only other providers, but the individual's family member, their friends, the context in which they live, so that we sort of stack messages up, so that maybe as a physician you can set the course, but then other healthcare providers can kind of keep it going. As a psychologist, when I see patients, just so everybody knows, when I hear a patient tell me the following, I know that I cannot help them change. And that is, I don't know why you're making a big deal out of this, because my doctor never talked to me about this at all. So I would say, as a behavioral psychologist, that physicians making sensitive recommendations and infusing hope around the potential for behavior change without doing any behavior change work, I find that incredibly helpful, because if the patient says to me, my doctor thinks that you can help me to figure out a way around this problem, that just makes my job so much easier. So,
maybe a question for the patients in the audience, or not in the audience, but over there. So Isaac in particular, but Glenn as well. Isaac, you mentioned that for a month you just stopped prophylaxis. We see that Sue-Ann referred to this as the prophylaxis holidays. But sometimes we don't actually understand, like, why does that happen? So I'm just wondering, you and then maybe Glenn, what are you thinking at the time that leads you to stop prophylaxis for a while?
Well, if you take needles 3 days a week, it sort of gets really tiring and it gets really annoying. So you don't want to wake up, get your box, mix it all up, and then just stick it in you. It gets annoying. Yeah.
It's like a movie that never ends.
Yeah.
It's like a movie that never ends. Yeah.
Just keeps going and going.
I mean, I'm lucky. I'm on extended life factor now, so I only have to infuse once a week. But yeah, there were times I just don't want to do this. I'm going away on a vacation. I don't want to haul this crap with me, right? And you got to keep it cold. You got to do it. You got to do it, because if you have a problem when you're somewhere out there, you're done. I've had the experience 12 or 13 years of having a bleed, the knee going out like this, getting out, ending up in the hospital for a month. You don't forget that, And it wasn't just 1 year; it was year after year after year after year, So for me, that's a lot of incentive to take my factor. What was really scary is after I came back from Toronto, and I had this piece of paper saying I can self-infuse. Well, I got home. I only infused twice in Toronto. So I got home, and here I am with this needle going to infuse myself, and I can't do it. I can't, and I'm the first person in New Brunswick that I can't mess up. So I'm panicking, and I go to my family doctor, this old country doctor. He was about 70. And I told him my problem. He says, well, let me ask you this question. Can you give a needle to someone else? I said, yeah, I could give you a needle, no problem. He says, okay, what we're going to do is he draped a towel over my arm, so all I saw was this wrist. And he said, give that guy a needle. That's what he said. All I could see was my wrist from here down, and it was like, okay, I'll give this guy a needle. And amazingly, it wasn't very long that I had that towel. I was only 13. I had that towel on my arm before I was, okay, well, it's not so bad, It's like anything. The more you do, the less scary it gets.
Thank you. Oh, Michael.
If you can indulge me 1 second. What you just experienced, I think, was exactly the point I'm trying to make. A physician expresses non-judgmental curiosity. And what you can expect is that when you do that sort of comment, you ask that, you're actually going to shorten the holiday.
Yeah.
Because you understand, you get it, you're not being judgmental. And so from a psychological point of view, that break that the individual patient requires, when that's kind of shared and understood, it will actually shorten the holiday. So that was a wonderful demonstration, I think, of what we're actually trying to facilitate in terms of really patient-centered communication.
Good job. And that concludes this session 3, and I want to extend my heartiest thanks to our speakers and panelists for today for such a wonderful job. Thank you very much.